coordinated it, and it was done meticulously by him and his colleagues in the field of gastroenterology. Navigate program is a very simple program in which we try to connect all the medical postgraduates in the country. And it was done meticulously by him and his colleagues in the field of gastroenterology. Navigate program is a very simple program. I'm really sorry, there's some technical glitch. So there's a resonance which is coming up. What is important is that we are trying to reach the most peripheral medical doctor who is unable to have the benefit of continued medical education. And this program is being live telecasted also on YouTube. As of now, I see that there's a 370 has the highly skilled doctors and faculty members who come and deliver the lectures. With these few words, I would again welcome all of you, especially the participants and Professor Govind Makharia, who very kindly consented to deliver this session. Thank you very much.
Thank you, sir. Thank you very much, sir. Now I would like to welcome a renowned speaker and the person I think who officially does not require any introduction. He himself is such a a person of big stature, Professor Govind Makharia, sir. So Dr. Govind Makharia is currently professor in the Department of Gastroenterology and Human Nutrition at AIIMS New Delhi. He is presently the president of Indian Society of Gastroenterology. He also has been the Secretary General of the Indian Society of Gastroenterology, and he initiated and nurtured many educational activities. Professor Makharia also has been a governing council member and chairman of Clinical Research Committee of World Gastroenterology Organization, which is the highest and most recognized professional organization in gastroenterology. Sir has been the member of academic committee of ICMR, DBT, JNU, and many other institutions. He has received numerous awards. He has trained 102 fellows in gastroenterology and 9 PhD students. He has published 346 articles in the indexed journals, 43 chapters for different books, and edited a handbook on celiac disease. The H index of his publications is 56, and his publications has been cited by 14,100 times. He has been listed among top 2% research scientists globally for last 3 consecutive years. And his main area of research is celiac disease. With this, I welcome you, sir. Again, now the session is over to Professor Govind Makharia, sir. Please, sir. Over to you, sir.
Thank you, Dr. Jaswant. Thank you, Dr. Kapil, Dr. Sareen, for a very wonderful initiative. And it's an honor to be a participant in this Navigate program. So in this Navigate program, we have been talking about common GI disorders. I hope I'm audible to everyone. All right. And in that series, we have been talking about common GI symptoms. In last 5 lectures, we discussed GERD, dyspepsia, and IBD. So today we discuss a very common topic, which is how do we approach a patient who comes to us with dyspepsia or with chronic diarrhea. So the learning objective of this webinar would be that how do we approach, or once patient comes with chronic diarrhea in our clinic, stepwise clinical assessment and stepwise investigation. What could be the right approach in such a situation? We know that diarrhea is very common, and almost 10% of our population, 10% of our population have chronic diarrhea. So it's a common disease. So number one question comes, what is chronic diarrhea? And there's a lot of confusion about it. What we call is the increase in frequency, increase in number of stools. Is it more liquid stool or liquid or fluid stool? Is it about volume, or is it about a combination of any of the three, any of the two? So the most important, we know what drives frequency. If somebody had more number of stool, the frequency is derived by rectum. Rectum is a sensitive organ, and that derives that is the cause for deciding frequency. Uh, I can see this cartoon. So it's about frequency or volume. Frequency may not be high in chronic diarrhea. It's all about volume. If volume is large and and it contains a lot of water, that will be consist of uh, chronic diarrhea. So what drives liquidity of stool? We all know liquid stool can occur in acute diarrhea because of a lot of GI secretion in the gut, or because of malabsorption, or if there is some secretion in the gut because of many tumors or carcinoma tumor, that can lead to secretory diarrhea. So volume is the most important factor in deciding chronic diarrhea. Second one, once whatever fluid is get in the small intestine is absorbed in large intestine and left out, which not absorbed from large intestine, is passed in the stool. Therefore, those many patients have a chronic diarrhea from small intestine, but colon absorbs and patient doesn't feel that the volume is large, but there's a disease in the small intestine. So colon is a severe. So we define diarrhea if frequency is more than 3 or stool volume is more than 200 ml. And it's very important to understand how do we decide more about it. These are the 6 stool types which we pass, type 1 to type 7. Type 3 is generally normal, type 4, 3, 4 is generally normal stool. If the stool stays longer in the GI tract for whatever reason, the stool become dry because colon will absorb water from that, and therefore uh, the stool become dry and become stick this kind of shape, and once it can break into small pieces. So this is a constipation. It means the stool is staying for longer period in GI tract. This is constipation. Those who have diarrhea, it means the water is not absorbed from the GI tract, and this is a 567 will be type 567 would be chronic diarrhea. Therefore, many patients will come that I pass stool like this, but I pay 3 times a day, but stool is this. This is not chronic diarrhea. Frequency is 3, but type of stool is not like diarrheal stool. It's important. The stool phenotype is very important. This is a type 567 is chronic diarrhea, and we must remember this in mind. We can download this picture from any of your phone or iPad, and or you take a printout and put in a clinic and ask patients that what kind of stool you pass. Type 1, type 2 is a constipating type stool. Type 567 are diarrhea type stool. And this is very important to use in clinical practice. As I said, that a lot of water comes in the small intestine, and colon, it get absorbed, and rectum decide frequency. So if you look at in summary, what will happen? Many patients can have a high frequency, so 4-5 stools per day, but a high volume, 500 ml, 300 ml stool each time, and content is watery. This is secretory diarrhea. This is not malabsorption. This is secretory diarrhea. This happens normally in acute infective disorders of intestine, and this is a secretory, but it happens chronic. It happens month after month. This is a chronic secretory diarrhea, and we must not miss that. And the cause could be, either cause could be some kind of neuroendocrine tumors. It could be many other infections, but mostly neuroendocrine tumors. If stool frequency is high but volume is low, this is large bowel type. If stool volume is high, frequency is high and volume also high or normal, this from small intestine. The point, please remember that anybody passing large amount of water stool, this is not malabsorption, this is not IBD, this is not IBS. This is secretory diarrhea. Anybody passing multiple stools a day, but small volume, this is again type 567 on Bristol School scale. This is large bowel type, and others are small bowel type. Now coming to small bowel type. Small bowel type have 3 main reasons of stool of diarrhea. One is mucosal disease. We know whatever we eat in the GI tract, they are absorbed, and once they're absorbed, they are, so therefore stool volume is normal. But if there's a diffuse disease of the small intestine, what will happen? Food will not be absorbed. Example, celiac disease, tropical sprue, immunodeficiency. In this situation, the GI tract mucosa is flattened. There's no absorptive surface. Therefore, there's no absorption. Therefore, they will have a chronic diarrhea. It can also be because of chronic pancreatitis, because of there's no enzyme. Therefore, food is not digested in the GI tract lumen. It can be because of bile disorders, or it is because of transport disorders. Food is absorbed. Is there introcyte? From introcyte to lymphatics or blood, it cannot go because of transport phase disorder, which happens in A beta or lymphatic tissue. And many parasites also leads to malabsorption. If you look at other in the large intestine, the most common cause is functional GI disease, and of that, irritable bowel syndrome is the most common cause, or functional diarrhea. The most common cause of chronic diarrhea in our country is a functional GI disorder. This could be because of IBS, or it could be functional diarrhea. Also can be caused by IBD and or by microsucculitis. Never forget, many drugs can lead to chronic diarrhea. Those patients who are taking metformin, and the only cause could be drug. And we keep working, we keep investigating in detail, but the cause is diarrhea. So we must keep in mind, in diabetics, metformin could be a cause of chronic diarrhea. Autonomic dysfunction because of any cause, including diabetes, and sometimes bacterial overgrowth can also lead to chronic diarrhea. I want to take again one more time of your attention that those people who have a large volume watery diarrhea for months and months, this is because of secretory diarrhea, and all because of neurohormonal disorders, some kind of tumor which secretes hormone like histamine or like many such hormones. There's a misnomer in our country that tuberculosis leads to chronic diarrhea. This is a misnomer. Tuberculosis does not lead to chronic diarrhea. Only 20% of patients with TB intestine have chronic diarrhea. So those patients coming with chronic diarrhea, it's not wise to give them ATT just based on that. So I'll take a case. This is a young girl, 16 years girl, who came to us. She had 3 years history of chronic diarrhea, had failure to gain weight and height. She had abdominal discomfort, has not eaten menarche despite being 16 years of age. She had generalized weakness, indefatigability, but had no joints pain. Her height and weight were less than 5 percentile. BMI was very low. She had anemia. She had pediatric edema, and she has not developed secondary sexual characteristics. The rest is normal. The question is a typical patient which we see in our clinical practice. Is somebody what she has, this young girl, of chronic diarrhea, has anemia, has growth failure, has gonadal failure, had cultural symptoms and malnutrition. So in this patient, how do I approach? So and to do that, we have divided this approach into multiple steps, and there are 8 or 9 steps. Question: is the diarrhea acute or chronic? First question: diarrhea less than 4 weeks is acute, more than 4 weeks is chronic. But acute diarrhea lasts only for 2 weeks. Is it functional or organic? This is very important. Functional are more common than organic. So this is the second question. Is small bowel type or large bowel type? I will come back. How do we decide that? What the volume of stool and content of stool? Is there associated malabsorption? Is it painful or painless? Is there abdominal pain associated with diarrhea? Does it have bleeding along with diarrhea, or is it inflammatory or non-inflammatory? So if you answer these questions in patients, making a diagnosis in chronic diarrhea is not difficult. I must assure you that. I told you that diarrhea lasting for more than 4 weeks is called chronic diarrhea. Coming to second step, functional or organic, and few things to keep in mind. That those patients who have anxiety symptoms, this could be functional. Those patients who say that after taking meal, I have to go to washroom, this is called increased gastrochronic reflex. This is suggestive of functional. If somebody has to get up in the night for passing stool, this is not functional. This is organic. It means the rectum is inflamed. If there's a weight loss, it may suggest organic. And if it's a very long duration, 7 to 10 years, that's likely to be functional. More important, if there's a gastrochronic reflex, eating meal, going to washroom, this suggests functional. and nocturnal diarrhea is organic. So coming to third point, that is a small bowel or large bowel, we know that the absorptive function occurs in the small intestine. If your small intestine is not good, mucosa is not good, then food will not be absorbed. Once food is not absorbed, there will be malabsorption. So we'll feel features of malabsorption. Second, in large intestine, if there is a ulceration in the GI tract, like rectal ulcers, like in IBD, then it could be blood in the stool. So how do you differentiate? If stool frequency is in small intestine is small, but large intestine is more, and we'd already discussed rectum decides frequency. If rectum is diseased, there will be more frequent stool. If volume is large, so just absorptive problem. If volume is small, so just large intestinal disease. Blood, mucus, and pus surely suggest large intestinal disease and surely rectum. So these are the points which can help us deciding where the site of disease. Volume and content to my mind is very important, very important. If there is a secretory cause, like neurohormonal disease, large amount of water is secreted in the GI tract, which cannot be absorbed, and therefore they pass large volume diarrhea. The large volume water stool confirms neurohormonal related disorders. And large volume stool which is a frothy or sticky, this suggests malabsorption. It means the patient will say that I have to flush a lot of water to clean the bowl of the washroom, and that's suggests malabsorption. If you examine this, if you ask the symptoms of these patients, if they have a weakness, bloating, flatulence, discomfort, or increased borboremy, suggest carbohydrate malabsorption. And if there is a body fat or there is storia, the stool, the fat in the stool, this is a fat malabsorption, suggesting fat malabsorption. And if we find the patient is lean thin, muscle mass is low, this suggests protein. So these are the features of mucosal disease, diffuse mucosal disease, and these are very important to ask. We must look for vitamin deficiencies, vitamin thiamine, riboflavin, niacin, pyridoxine, and I think all of us are aware about it. Second question, I just discussed that the cause of diarrhea is both inflammatory and non-inflammatory. If there is a joint pain or fever, this suggests this is diarrhea maybe because of inflammatory disorder. And this could be tuberculosis, Crohn's disease, ulcerative colitis, and many other disorders. So asking about fever and joint pain is also very important. But in those disorders where there's diffuse mucosal disease like celiac disease or tropical sprue, there will not be fever or joint pain. If there is it's a conceptual that if there's a disease for celiac disease, which is a diffuse mucosal disease, and intestinal lumen is normal. If you take example of IBD, Crohn's disease, there's a mucosal disease, there's mucosa is ulcerated, but along with that, there's a stricture in intestine. If there's a stricture, there will be pain abdomen, there will be intestinal colic. So therefore, if diarrhea is there with intestinal colic, this suggests a luminal component also, and this suggests IBD more often than celiac disease. Or it could be because of Whipple's disease or chronic pancreatitis. Chronic pancreatitis with chronic pancreatic insufficiency can lead to exocrine insufficiency and can lead to chronic diarrhea. Therefore, it's good to ask if there's a pain of intestinal colic, so just one of these diagnoses. If there's no pain, then one of these diagnoses. So coming to last important point to differentiate, if there's a GI tract along with diarrhea, if there's a bleeding, it means somewhere there's ulcerations in the GI tract, more often the rectum or distal colon. If there's ulceration in distal colon, there will be blood in the stool. Therefore, if blood suggest is there in the stool, is either IBD or tuberculosis, but these disorders will not have blood in these patients. So putting all of these information which we asked in the history will give us a lot of information and help us decide. So let's summarize everything together in this individual. We remember this young girl who had recurrent diarrhea. Diarrhea was of small bowel type. She has a high volume stool. She had features of malabsorption. Why she malabsorption? Because she has anemia. She has growth failure. She has gonadal failure. So malabsorption. She had no pain. She had no joints pain. So non-inflammatory features. And there was no blood in the stool. All of these points, these last 5 points suggest there's a mucosal disease of GI tract and of small intestine where food is absorbed. So the whole GI tract is now is affected by some kind of disorder, which is called mucosal malabsorption. So C has a predominantly mucosal disease of GI tract, of small intestine, and there's no prominent luminal symptom. Luminal symptoms means no pain. So what are the causes? In small bowel diarrhea, we have two main major things. One is with malabsorption, and malabsorption means what? Stool characteristic, which is large volume, frothy stool, sticky stool, anemia, signs of deficiency, both macronutrients and micronutrients. And if this is a situation, then our differential diagnoses are celiac disease, which is the most common. We believe celiac is not common in our country. This is not true. Celiac is very common in our country, and there's no data from our country that about 1% of our population, one in 100, have celiac disease. Other ones are tropical flu, parasitic disorders, immunodeficiency, and other uncommon disorders. If there's no malabsorption, then this could be because of bile acid diarrhea or because of secretory diarrhea. Bile acid diarrhea is also poorly recognized, is not that uncommon. And secretory diarrhea, I told you, if there's large volume water diarrhea, this is a secretory diarrhea. And these patients would be referred to higher centers. If diarrhea of large bowel type, then again, we divide into two types, either functional or organic. Functional is most common. Functional is either IBS or functional diarrhea, which we decide by Rome 4 criteria. And if it's organic type, then with blood is inflammatory bowel disease, either ulcerative colitis or Crohn's disease, because of tuberculosis or sometimes because of tumors. Without blood, drugs, you must remember metformin and other disease is microcystic colitis, where there's a large intestinal mucosa is mildly diseased. There's no ulceration, but the absorptive function of colon is impaired in these patients. Coming back to patient again, she had a younger, small bowel type of diarrhea with major nutrient deficiency, carbohydrate. She has symptoms, fat, she was very lean thin. She has no muscle mass, so there's a somatic protein loss. She has anemia, she has riboflavin deficiency, she has delayed menarche, non-inflammatory, non-painful. What the diagnosis? So this is a diffuse mucosal disease. With that diffuse mucosal disease, now how do we confirm? For confirmation, we have three principles. Principle number one, that assess the effect of diarrhea, like malabsorption, anemia, growth failure, like things. You want to test the structure and function of GI tract and then find etiology. And all of these can be done by a test. Looking first for effect of malabsorption. We do hemogram, CBC. She has anemia, which is iron deficiency type because MCB is low, and peripheral blood flow is microcytic hyperchromic. So she has a iron deficiency anemia, and she also has a low B12. Her LFT was normal, but also I'll give you one more hint out here, but in next a few minutes. His LFT, RFT are normal. So what test we do in this situation? To confirm malabsorption, the test called D-xylose, this tells us about carbohydrate mucosal malabsorption. This test is not available everywhere, but again, this is a good test to do. One can measure stool fat and see that how much fat is there in the stool, and we can assess that there is a malabsorption. But more important, look at the site of disease. We just decided this girl has a mucosal malabsorption. So you want to look at small intestinal mucosa and take biopsy from there to look at Cripp-Willis architecture from where the nutrients are absorbed. So you do upper GI endoscopy, look at different part of intestine, and sometimes we do colonoscopy if there's a large bowel type, take biopsies and look at absorptive structure. There's no need to do a CT or MRI in every patient unless there is a luminal disease. Those patients with chronic diarrhea, if there's a pain, then we do CT or MR angiography. Again, I want to say one more point out here that whenever we want to do CT scan in patients with GI tract luminal disease, like a small or large intestine, always do CT angiography, not CECT. So D-Jalus test, I will not have time to go in depth, but her D-Jalus test was abnormal, and this suggests that she has a mucosal malabsorption. Stool fat does assess that how severity malabsorption. Stool fat is more than 7 grams in 24 hours. This suggests fat malabsorption. So what tests we do? For etiology, we do stool test for parasites, serological test for celiac disease. We do immunoglobulins for immune deficiency disorder and retrovirus. And if there's a doubt of bacterial overgrowth, then do glucose hydrogen breath test and biopsies every time. So for stool, we do special stains. I'll skip that. The celiac disease is, as I said, is one of the most important cause of malabsorption in our country. And the test this can be detected by 3 tests, but the most important test is anti-tissue transglutaminase antibody. This test is very sensitive and very specific. This is a Elizabeth test. It's widely available. And if you ever think of celiac disease, you screen these patients by using anti-TTG antibody. And it's a great test to do. So in this patient, stool showed giardia, and his TTG antibody was remarkably high. So this patient had celiac disease, but you still want to confirm. For that, you do upper GI endoscopy and take biopsy from small intestine. This is normal intestinal mucosa looks like. This is the duodenal folds. These folds are mildly atrophic mucosa. This is a very atrophic mucosa, suggests there's some kind of mucosal disease. This is again showing scalloping of folds. These are, if we find this kind of picture, this is suggestive of very important disease. This is called nodal lymphatic aplasia, and this suggests CVID, common variable immune deficiency. Sometimes we find these kind of pictures, which is called nodal lymphatic aplasia and suggestive of celiac disease, CVID. This picture suggests lymphatic disorder. These are lymphatic which are now going to rupture and can lead to this. We must obtain biopsies every time, even because it's normal, and biopsy is one of the very important thing. If you have biopsy, we can diagnose many disorders on this, like giardiasis, lymphatic ectasia, or tumors. But many times we find biopsies which, looking at cryptovillus architecture, and you find atrophy of those, which suggest celiac disease or different infections. Like this is normal mucosa. So this is a villus, this is villus, and this is a crypt. So this ratio is 3:1. Villus is have more height compared to crypts, and this becomes abnormal in mucosal disease. Now these are all crypts. These are all crypts are elongated, no villus. It means there's a villus atrophy, and this is a feature of celiac disease or tropical sprue. So this is again in picture. You find this is normal mucosa. You find here's an increase in inflammatory cells and mostly ELs. There's intraepithelial lymphocytes, and as disease progresses, this mucosa become atrophic like this. There's a hardly any villus, but more crypts. So biopsy is very important, and which gives a lot of information. So in this patient, we talked about a 16-year-old girl. This mucosa shows, this is called, this was the kind of duodenal mucosa the patient had, and the biopsy was severe villus atrophy. We already knew this patient has increased TTG antibody. So diagnosis in this patient was celiac disease. A question all people always ask that, do I do a CT scan in them? There's no need to do CT scan in them because we are thinking only mucosal disease. We are not thinking luminal disease. Therefore, CT is not to be done in this situation. So in this patient, we had this patient had chronic diarrhea with malabsorption. She has positive celiac serology. She has villus atrophy, and therefore diagnosis celiac disease. So how do we treat, or how do we make a diagnosis? Tropical celiac disease is based upon symptoms, serology, and biopsy. Parasitic disorders, you find stools, parasites. Immunodeficiency by either by HIV test or by low immunoglobulins, and others are uncommon. IBD we diagnose by a combination of clinical, endoscopy, and histology all together. And if none of them are there, then we treat them like tropical sprue, which is diagnosis of exclusion. So this is an approach that if you think of patient with malabsorption, then if they have malabsorption, do hemogram, two type of anemia, do biochemical tests. If there's low albumin and calcium or phosphate, depending upon etiology or your clinical situation, you will do these investigations. As I discussed in this patient, you find all of the tests are negative, then you diagnose tropical sprue. I think with that, I'll stop here and take any questions.
Thank you, sir. Thank you for such an informative session. And I would like to say that your presentation made it easier to differentiate from large bowel and small bowel type diarrheas. Also, like the learning was made interesting, sir, using the case-based diagnostic approaches, using those two cases. Yeah. So thank you, sir. We have got two questions over YouTube, sir, that I would like to read out for you, sir, please. One is that, sir, what should be the clinical approach to differentiate between chronic diarrhea and IBS diarrhea type, IBSD type,
Say it
subtype?
again. Say it again. What the question? Say it again. What the question?
Sir, what should be the clinical approach to differentiate between chronic diarrhea and IBS-D subtype, मतलब diarrheal subtype?
So chronic diarrhea, any diarrhea lasts for more than 4 weeks is chronic
Right.
diarrhea, right? I said the 10% of people in our country have chronic diarrhea. Majority of them are functional diarrhea, right? Functional diarrhea are of two kinds, is IBS. IBS, we know, irritable bowel syndrome, 3 types, IBS constipation predominant, IBS diarrhea predominant, and IBS mixed type, right? So of that, and other condition called functional diarrhea. So if there's a pain abdomen present, pain and diarrhea is called IBS-D. If it's no pain, then functional diarrhea. This is how we differentiate. So if you diagnose as functional diarrhea, the question is it IBS-D or functional diarrhea? If there's a pain, then this is a IBS-D. IBS is the pain is important. In functional diarrhea, there's no pain.
Right, sir. Thank you, sir. Another question has been asked, sir, that some of the Ayurvedic or homeopathy practitioners claim to cure celiac disease. Any scientific literature available, sir?
I'm not aware of, but I will doubt, because celiac disease is one disease where we know why it happens and how to treat. This happens because of ingestion of gluten, with a protein in wheat, barley, and rye. This protein, some patients cannot digest because this has a proline and glutamine amino acids are quite high. And these peptides, which are partly digested, they induce immune system in some patients who have genetic susceptibility to celiac disease. And unless you stop wheat in them, disease cannot be ever cured. So I cannot, I don't know how they work, but I will have my serious doubt that unless you stop wheat, the patient will not be better. Unless the diagnosis is wrong. You're saying celiac disease based on something else, diagnosis is doubtful, but celiac is the diagnosis, then lifelong wheat-free diet is the treatment.
Right, sir. Right, sir. Right, sir. Thank you. Thank you very much, sir, for such a informative and wonderful session, sir. And we can understand the shortage of time. So with this, now I would like to welcome Professor Ajay K. Sood, Deputy Secretary of National Academy of Medical Sciences, for the word of thanks. Over to you, sir. Sood, sir, please.
Thank you, sir. On behalf of the National Academy of Medical Sciences, it is my great pleasure to thank the distinguished speaker, Dr. Govind Mukharia, sir. I know you were busy in a very important meeting, so thank you so much for sparing time for our students. I am sure that the practical tips which you have given for management of chronic diarrhea and malabsorption will be very, very useful for us. Thank you so much, sir, for your support and blessing. I would also like to
thank you so very much. I think I enjoyed this session very much. My apology that I had to leave early. Thank you, Dr. Sood, Dr. Kapil, Dr. Sareen, Dr. Jaswant. Thank you so very much. And everyone who joined this meeting.
Thank you, sir. Thank you, sir.
I also like to thank Dr. Jaswant for moderating this session. And once again, our apologies for the initial glitch which our IT unit had. I'm sure that the participants have enjoyed this session. And for the information of the participant, the last session in the series of gastroenterology is on 16th of February, where the topic is management of acute pancreatitis. So please do join us. And meanwhile, if you're interested in management of cancers, that is immunotherapy in cancer, that session we have on 2nd of February. The time is same, 3 p.m. onward. So with these words, I would like to thank all of you for being with us and making this session interesting. Thank you so much. Over to you, Dr. Jesus.
So thank you, sir. With this, we mark the closure of the session. So with the permission, sir, we can close the session. Thank you, sir. Thank you, everyone. Thank you, all the participants.